PG activity being organized by West Bengal Academy of Pediatrics. The concept of this meeting was that it would be a teaching activity for the postgraduate students who are the budding pediatricians in the near future. Today, our President, Professor Kalpana Datta, along with our Secretary, Dr. Indranil Chaudhary, we have got experts, Dr. Sandhya Pathshala of NRS Medical College, HOD. We have Professor Miran Kanti Das of SSKM Hospital. We have got two mentors, young mentors, Dr. Sumantra Rao and Dr. Niladri Bose. So I will request Professor Kalpana Datta to start the session, please.
Yes, thank you, Dr. Roy. I first of all, good evening to everyone, all the faculties and the participants and these presenters, mentors, and all the experts. Welcome to this second class on Sandhya Pathshala, and this is a totally clinical case presentation sort of. We cannot reach physically to each other to have a knowledge from and gather the knowledge from all the seniors faculties. So we started this Sandhya Pathshala so that we can have our knowledge, exchange knowledge, and we can gain clinical skills. The last class was wonderful, and we had a very good lessons learned. I hope this session will be also very good, and we'll learn a lot of clinics and the cases. So thank you all. I'd like to ask first case. Dr. Niladri is the mentor. Where is he? I can't see Dr. Niladri. Are you here, Dr. Niladri?
Sumantra is there.
So Dr. Sumantra.
Yes.
Dr. Sumantra Rao, he is DM nephrology, very dynamic and academic, always on the field. He never stops anyway, always in move. So we are very lucky to have you. Just you introduce your student and ask him to present the case. Start the case. And the experts will be asking questions. Till then, all the participants and the faculty, please mute yourself. And only the experts will ask the question and answer will be there. Then the mentors will say some expert comments. And if you have any queries or any answer of the questions, you write it in chat box, please. So,
okay,
Sumantra, please.
Okay, ma'am. So our the first case is going to be a case of from pediatric nephrology. Dr. Prashant Gupta, he is second year DNB PGDs at Neutia Bhagirathi Women and Child Center, Newtown, and he will be going to present the case today. So, Dr. Prashant, are you ready?
Where is he?
He is there, ma'am. He has already done a test trial with Somnada. I'm not sure the voice is cutting or not.
Prashant, unmute yourself, unmute and share your screen.
I think he has bit net issue. Just check your net connection once. Mostly some yellow towers are coming. If it is okay, then you can first unmute and respond with the voice chat, and then okay,
okay, good.
Good evening, everyone.
Make it slideshow mode, large.
प्रसन्न स्लाइड शो में जाओ और स्लाइड शो कर दो. हाँ,
yes.
फर्स्ट स्लाइड से दिखाना. दिस इज द सेकंड स्लाइड, आई थिंक. You can start now. Ma'am, is there any time limit? Kalpana ma'am?
There is no time limit.
Okay ma'am, fine. Okay sir. ठीक है प्रशांत, you can start.
Good evening, everyone. So today I am presenting the case of pediatric nephrology. A child X, 8 years, 2 months, female, residing at Kolkata, now settled in US since last 4 years. The informant was mother, a reliable source. The child was admitted on 28th August 2022 and been examined on 29th August 2022. The child came with the complaints of generalized body swelling on and off since last 1 month, which increased since last 5 days more. And there's complaint of decreased urine output for last 20 days, which was more decreased so in the last 2 days. Then going for the presenting illness, child 8 year 2 months old female was apparently all right 1 month back. when child was brought with complaints of puffiness around the eyes and face for 1 month, which was insidious in onset, gradually progressing from initially starting from the periorbital region, then involving to the whole face, legs, and followed by abdomen involvement. The child was admitted in our hospital 2 weeks back for the complaint of puffiness, which was improved partially by giving some IV medications. The mother then noticed again increase in swelling of both lower limbs after 5 days, which was gradually progressing from feet to knee, involving symmetrically, and later involving both upper limbs, which was noticed more during the morning time. The generalized abdominal distension was insidious in onset and gradually progressing. Then there is a decreased urine output for 7 days before admission, that is on 15th August 2022, which improved on IV medication with the disappearance of swelling. But again, urine output dropped since last 2 days. And then this was the image where there is a puffiness of present around the eyes and involving face also. And the complaint was not associated with any breathlessness or exertion, chest pain, or recurrent cold and cough, or bluish discoloration of nails. There was no history of jaundice, vomiting, on any bleeding manifestations from any side. There was no history of loose stool or any growth retardation. There was no history of heat, cold intolerance, or dry skin. There was no history of lip swelling or any itchy rash. There is no history of red or cola-colored urine or any sore throat episode. No history of burning, micturition, dysuria, or increased frequency of urine or any leaking of urine present. No history of recent diarrhea, painkiller use, or any unknown bite history. No history of seizure, headache, joint pain, and no history of fever or pain in abdomen. Then the part of treatment history, child was admitted 2 weeks back in our hospital, where blood and urine investigations were done and USG was done, which showed some kidney issues.
Prashant,
And
you
the
can
swelling
switch off your
improved on
video.
IV medications.
You can switch off your video.
According to the mother was giving some oral.
Prashant, your voice is breaking. Excuse me, Prashant, your voice is breaking.
You
You
just
can
switch
switch
off
off
your
your video.
Twice daily in full stomach since then, and have been told to give it for 6 weeks in the same.
শুনতে পাচ্ছি না মনে হয়। Prashant, your voice is breaking, beta. You can switch off your video, so that's why it comes pretty clear.
Yes, yes.
Are you audible? Okay, continue.
Please stop video. Okay. Prashant, continue.
Sorry.
Ma'am, probably some net issue leave করে গেছে, rejoin করছে, probably rejoin করছে।
Okay, okay. No issue.
Prashant, you
let
switch
him
off
go.
your video
Let him.
so that the net issue can be solved to some extent.
I did that. Now is it also audible clearly?
Yes, yes.
Yes, ma'am. So on the treatment part, the child was admitted 2 weeks back in our hospital, where investigations were done and some kidney issue was found. Swelling improved on IV medications. The mom was giving history of some oral tablet twice daily in full stomach since then for 6 weeks in same dose, and SOS tablet if swelling increases, which was since last 2 days. And mom
No sound.
hello,
Can't hear.
still no
শোনা
sound.
যাচ্ছে না বেটা?
Yes, sir, I am.
अभी बोलो। Last line सुनाई नहीं दिया। Last line बोलो।
Mom was told to do urine dipstick daily and to maintain a diary maintaining with the medicine dose. Sir, it is audible.
Yeah, फिर भी break हो रहा है intermittently.
If you are not
Tell
audible, we will tell it. You just continue.
Yes, sir. Then there was no significant past history. The child was first born out of non-consanguineous marriage by LUCS at term immediately cried by at birth. There was no history of an ICU stay, no history of any parental complication. The child development was as per normal peers, and the child is in currently grade 3rd studying. The child was on the dietary history. The child was exclusively breastfed for till the 6 months of age, and then after weaning was started from 6 months, and family pot diet was started since 18 months. The child is receiving mixed type diet with a non-veg of 5 to 6 days per week. The bowel history was regular, no constipation history was there, and the child has been vaccinated according to the national vaccination schedule, and also received vaccination of flu, pneumococcal, and varicella. On the family history, there is no history of nephrotic syndrome disease or any chronic kidney issues. There is no history of tuberculosis or diabetes. According to the socioeconomic status, they belong to upper middle class as per modified Kuppuswamy scale. On examination, vitals were heart rate 106 per minute, BP was 124 by 94, all four limbs having similar pulse.
Dr. Prashant, just wait and let the expert
Yeah.
ask if any history, further history they wanted to know. So now
Yes.
I'll ask the Dr. Tapun Sinha sir and Dr. Minal Kanti sir. If you want to ask anything to the student, you can go ahead. Then he will start the examining part.
Dr. Prashant. Dr. Prashant. Hello.
Yes, sir. Yes,
I'm
sir.
Dr.
Audible.
Okay. So in the history part, the patient was readmitted, na? Patient
Yes, sir,
was
readmitted.
initially admitted and diagnosed and was on treatment, and the
Yes,
patient
sir.
was readmitted. Then what was the cause of readmission? Aggravation of
So
swelling.
basically, yes, sir, increased swelling on face and limbs, and basically involving abdomen also.
Okay. After getting how many days of treatment?
Sir, she almost received treatment for 8 weeks.
Huh?
Sir, almost 8 weeks.
8 weeks.
Yes, sir.
8 days. 8 days or weeks?
No, sir. Sir, initially the child was admitted on 25th, around 14th August. Then after receiving treatment, the child was again readmitted on 27th. That is around 14 to 15 days, sir. For the
Okay.
first
That means after 2 weeks. After 2 weeks of first discharge.
Yes, sir.
After 2 weeks of getting the specific treatment.
Yes, sir.
Is it?
Yes, sir.
Okay. Okay. So in the history, what is important? What is important here? The patient, by this time, the patient should have some improvement. Here, there was deterioration. What may be the cause for that?
Sir, for initial few days, the child was improved, there is swelling decreased, but as the IV drug medications were stopped and the patient went home, then after she was on only oral medications, and that's the time where the child again deteriorated starting.
Okay, there is no history suggestive of any infection anywhere.
No, sir, not at that time.
Okay. Okay.
Any questions from Tapan sir?
I think question should continue.
Without, can I, with permission, the chairperson, can I ask some question?
Yes.
Okay, so without seeing if the patient is state sensitive or all, you have discharged after giving the treatment. You have not stabilized whether the patient is a steroid responsive, steroid resistant, whatever it is. So too early discharge. What is the reason of?
When we started the oral prednisone treatment from here only, and the urine protein was started decreasing, that is initially at the time of admission, it was 4+, and then it started decreasing on a bit of 2 to 3+, and the swelling also improved.
But not in remission, not in remission.
Yes, ma'am. She has at least not received full remission.
So, you have discharged prematurely, no? Ideally, it should be in remission, 3 consecutive urine protein will be free of protein, then only should be discharged.
At that time, 3 urine protein was there. 3 days urine dipstick was negative, that is less than 2+. So we discharged the patient with oral medications.
Okay. Okay, thank you.
Shumantro, I just want to ask you one question.
Yes, sir.
Is
Yes, sir.
it 1+ or 2+ proteinuria when you call it a remission?
No, sir. The child didn't went to remission. For nephrotic syndrome, if the edema control is there, we have admitted the child first episode for edema control. Whenever the edema is being controlled, the child can be discharged. If the child is stable, can be discharged, can continue the medication and a good urine diary at home. And then we can follow up in OPD basis also, because they are mostly going to be immunosuppressed. So unnecessary hospital stay we usually avoid. And plus such a long stay, some child may become in remission after 4 weeks, some may after 5 weeks or 6 weeks. So a long stay is better avoided. If it requires some IV medications or intense monitoring to hospital, then we can keep to the hospital. जरूरी ना कि सबाई के full remission प्रमाण करे discharge करते हुए, we can discharge the child also. It is a rule कि once hospitalization need is over, the child can continue the same drug daily up to 6 weeks. In between, those patients are delayed sensitive or in resistant patient, they will have intermittent edema. They will have to get admitted intermittently. প্রচুর পেশেন্ট আছে যারা প্রতি সপ্তাহে একবার করে ভর্তি হয়, দুদিন একবার নিয়ে আবার বাড়ি যায়। এই করতে করতে যখন 6 weeks cross করে, we label them as resistant.
We have got a lot of students from outside West Bengal. So
Okay,
better
sir.
speak in English.
Yes, sir. No
Because
issue,
my
no issue.
PGDs are also joining.
Okay, sir. No issue, no issue. So our priority is not to discharge the child only after documented remission. We can discharge the child whenever hospitalization need is over. That means the edema control part is over, and the child can continue the same steroid, same medications as per the stipulated time. In interim course, if the child reappears of edema is there, we can again readmit for short time to avoid unnecessary hospitalization and hospital acquired infection.
I would like to add one thing, Shumantro.
Yes, ma'am. Yes, ma'am.
And mother is trained. If mother is not fully trained, and this is very difficult to discharge the patient. So counseling and the training of the mother.
That's true, ma'am. Right, ma'am. That's why I told a good diary. But not only trained, they have to document that they are giving the medicine. Otherwise, we don't believe in giving medicines unless the child is cushingoid or the mother has a good diary. Okay, ma'am.
Hello, I think the presentation is only history is there. So we should not discuss regarding nephrotic syndrome just now. Just make him complete the examination part and put the diagnosis that it is a case of nephrotic.
Right, sir.
Okay, Dr. Prashant, continue.
Then on examination, vitals, heart rate was 106 per minute, BP 124/94 mmHg, all 4 limbs having similar pulse. BP was more than 95th centile, pulse volume was good, respiratory rate was 28 per minute, saturation was maintaining, she's 98% at room air. The temperature was normal, with extremities a little bit cold on touch. The weight was 29.6 kg with a z-score deviation of -0.2, and appropriate dry weight would be 24 kg as calculated. Height 134 centimeter, BMI was 13.37 with a SMR staging of stage 1. On general examination, a well-looking child, anasarca present with parietal edema and vulval edema present. No pallor, no icterus, no clubbing, no cyanosis, no rashes, no lymphadenopathy, and no abnormal facies present. On systemic examination, on abdominal inspection, there was distended abdomen with umbilicus horizontally slit present, no visible scar or dilated veins present, no any red patch present, no abnormal mass seen at rest or during coughing. On palpation, there was no tenderness present, abdomen soft with a girth of 67 centimeter, and no hepatosplenomegaly present. On percussion, there was presence of ascites with fluid seal and shifting dullness present, and no hepatosplenomegaly. On auscultation, bowel sound was present, which is gurgling in nature. No hernia or no other genital deformity present. Rest other system examination, respiratory system was normal, bilateral air entry present, no distress or any added sound present. On CVS examinations, heart sounds S1, S2 were normal with no S3 heard, no murmur. JVP was normal, and the child was conscious, alert with no focal deficit. So should I go further?
In the examination part, Dr. Prashant,
Yes, sir.
you have mentioned the blood pressure
Yes, sir.
more than 95th percentile, right? So
Yes,
that
sir.
means you want to say it is in stage 1 hypertension.
Yes, sir.
Stage 1 hypertension, both systolic or diastolic?
Yes, sir.
Both.
Yes, sir.
Is your idea if suppose only diastolic or systolic is more than 95th percentile means stage 1, will you call it hypertension or not?
Yes, sir. It will be called hypertension. Any of the parameters will be needed. Either it's systolic or diastolic.
Yeah, very good. In percussion part, why you have mentioned hepatosplenomegaly? Percussion, that is mistake. Na? Ascites plus no hepatosplenomegaly.
Sure,
So
sir.
I think it should be deleted.
Yes,
And
yes.
in examination of other system, in a patient who is having usually bloated appearance with valval edema and ascites, what is expected in respiratory system examination?
Sir, distress is expected if there is any presence of pleural effusion.
If there is pleural effusion, in which side most common?
Sir, air entry will be
As
decreased
part
on
of
the axillary regions.
Which side, left or right? As a part of NSR. It is on the right side. It is on the right side, which is most common as a part of NSR.
Yes.
Okay. Okay. So your examination part is over.
Yes, sir.
Next. Go ahead.
So on a part of differential diagnosis, we have the following differentials, that is starting from nephrotic syndrome, as there is a favoring presence of anasarca with no red urine. But what was against on this favor is that is the presence of a hypertension with a bit older age onset. Then nephritic syndrome can be there as presence of anasarca and decreased urine output, but there was no history of sore throat or red or cola colored urine. In renal failure, there was puffiness present with low urine output, but no history of any acute onset disease like diarrhea or any unknown bite, no history of poor growth or lower upper tract infection, urinary tract infection. On part of chronic liver disease, there was ascites present, but no icterus or not any bleeding manifestation was there. As a differential of congenital cardiac failure, there was presence of anasarca, but no breathlessness on exertion, no decreased physical activity, no cyanosis was present. On part of lymphedema, there was anasarca present, but it was symmetric. On the favor against favor was that it was symmetrical involvement with abdominal swelling, which is rare in lymphedema. Lymphedema, it is mostly unilateral involvement and unsymmetrical. Then on the part of angioedema, there was anasarca present, but no history of any rash or drug intake.
Okay. In differential diagnosis, your first is the nephrotic syndrome, and
yes, sir.
Nephrotic syndrome, only point against you have mentioned hypertension. So
yes.
What do you think? What do you think? How you can justify that hypertension, it is your against point, but still how you can explain hypertension in this patient? One, it could be a case of nephritis syndrome, but point against, so many points are against. Can you
Yes, sir.
mention some? Nephritic syndrome.
Yes.
What about decreased urine output in case of nephrotic syndrome and in case of nephritic syndrome? When it starts?
Sir, in nephrotic syndrome, if there is a presence of hypovolemia, then there can be a decreased urine output.
So it takes time, a few
Yes, sir,
days
but it
time.
takes time to develop.
But in nephritic syndrome, it is from the very beginning.
Yes, sir.
That is one point. That is one point. And the duration of illness. Here, the duration of illness is
Sir,
more, and the
more
swelling is
serious.
increasing.
Yes, sir.
The swelling is increasing. By this time, PSGN usually the swelling starts decreasing.
Yes,
Now,
sir.
regarding hypertension,
Sir, it can be a secondary onset hypertension due to renal involvement.
okay, it could be secondary, okay, or stage 1 hypertension. Whether in primary or idiopathic nephrotic syndrome in children, I mean MCNS, hypertension is found or not? May be found.
Sir, may be found, but it's rare.
In first episode, if it is found, it is transient due to severe hypovolemia.
Yes.
It has. So renin-angiotensin system maybe.
Involved, sir, because of increased sodium
So
reabsorption.
hypertension, transient hypertension, you may get.
Yes, sir.
Okay. Go ahead. Go ahead.
Okay, sir. So our provisional diagnosis was made as first episode of idiopathic nephrotic syndrome, admitted for edema control. Then on the management part, complete blood counts were done with a renal function test to have a baseline of urea, creatinine, sodium, potassium levels. Serum total protein was done. Serum albumin and cholesterol levels were done. SGPT levels were done. Then urine routine for urine protein and RBCs were done. 24-hour urine protein or spot urine protein creatinine ratio can be done. We did a spot urine protein creatinine ratio, and Montoux test we did, followed by USG KUB. Then on the management.
Before management, the routine investigation in case of first episode nephrotic syndrome, idiopathic nephrotic syndrome, which you are suspecting.
Yes, sir.
I want the comment of Dr. Rao regarding the sodium potassium, routine sodium potassium in first episode nephrotic syndrome.
Yes, sir.
Electrolyte. Yes, it is given in guideline. That's why I am asking you.
Sir, if the child is admitted for edema control, then sodium potassium is required because usually
suppose
they have a hyponatremia. If a stable child coming to the OPD will mild edema, which we are not admitting, maybe not giving even oral acids also, might be with steroid we are expecting a decrease in edema within 5-6 days. Their sodium potassium is not necessary. It's only a reason
Fine.
because nephrotic syndrome has a high ADH amount. Huge amount of free water is being absorbed. Usually they have a borderline low sodium most of the time.
Low
So
sodium.
that's
Yeah.
why whenever we are using a huge edema control, like use high dose of Lasix or albumin we are trying to give that, and we are restricting sodium also that time. That time, at least for the edema control period, daily sodium potassium at least once a day is required, along with urea and hemoglobin.
So I think the take-home message should be: it is not mandatory as mentioned in guideline.
Right.
The sodium potassium in each and every case of first episode as routine investigation.
Right.
Here, Prashant, you are interested to see ALT, SGPT. Why?
Sir, because of if there is any liver involvement or not, or any underlying secondary hepatic cause for the nephrotic syndrome.
The first investigation, what you like to do when your provisional diagnosis is nephrotic syndrome? First investigation. I think it is urine analysis.
Sir, urine
And if you
protein.
get, and if you get massive proteinuria, then it's obvious that you are dealing with a patient of nephrotic syndrome.
Yes,
And then
sir.
you can plan your investigation accordingly. Right?
Yes, sir.
Give comment regarding 24 hours urine protein estimation versus you have written spot urine protein creatinine ratio.
Sir, because basically 24-hour urine protein gives a more accurate result, but here it depends what is more easily available. That is the spot urine, which is more easily available and to do procedure as compared to 24-hour urine protein collection.
So in pediatrics, spot urine protein creatinine ratio is enough. So 24 hours urine protein estimation is not mandatory in each and every case. Yes, it is required in selective cases.
Yes.
Protein creatinine ratio, and what is the ratio?
Sir, it is, sir, for nephrotic range, it should be more than 2.
More than 2. Fine.
And normally it is less than 0.2.
Okay. And in routine microscopical examination, what about this RBC? Comment.
Sir,
Yeah.
Sir, if there is a presence of RBCs, then it will be favoring towards more nephritic syndrome. That is where is hematuria present. Or in certain few cases where in nephrotic there is a presence of gross or hematuria is there, or microscopic hematuria, then we have to go for the further evaluation of the child for further tests.
So take home message is usually in case of childhood nephrotic syndrome,
it is sir negative or very RBCs present.
Okay. Okay. Now comment regarding this Mantoux test. In first episode, nephrotic syndrome, just you got, suppose if the first admission, during first admission, you have said you have done it. So
yes,
is it mandatory or not?
Sir, it is mandatory just because we have to start the main treatment for nephrotic syndrome is steroid therapy. So before starting steroid, we have to rule out if there is a presence of any tuberculosis or not. So that accordingly we have to start the treatment. So that's why we, for the first episode, we try to have a Mantoux test or X-ray test to rule out tuberculosis.
Both. You are saying both. Mantoux test and chest X-ray.
Sir, Mantoux is basically done.
Yeah. And if Mantoux positive or
then
some
we have
respiratory findings, then
testing.
For that. What about USGKV? Is it routine, mandatory?
So it's not mandatory and not routinely done, but we can do that to rule out any.
No, we can do so many things, but USGKV is not
routinely. It is not necessarily done.
Yeah. Dr. Raut.
Yes, sir.
Anything else?
Point well taken. Actually, Mantoux test was only for first during first admission. Repeat Mantoux test is not required. And as per ISPN guideline 2021, at least for Indian setting, better to have only Mantoux test if the child has no other symptoms. So for no other chest symptoms or clinically chest findings are okay. Chest X-ray we don't read on a regular basis. But if wrongly the Mantoux comes as positive incidental finding, then we have to now decide the child is having active TB or just a Mantoux positive child. So that time we need to do either sputum GLC BNAT or a sputum AFB along with some chest X-ray. And on this evaluation, if the things comes positive, then we need to start full dose of ATD and give a 2 weeks of sparing time, and then after 2 weeks we can start prednisone in full dose. But if the isolated Mantoux test is only positive and no other TB screening is positive, the GLC is negative, SS is normal, child is asymptomatic, then we can start only INH prophylaxis for total 6 months, and at the same time on the same day we can start full dose steroids. This is the ISPN guideline only. IPNA guidelines is a little bit different because it's vary as per the country's prevalence of tuberculosis and like this. And ultrasound, you have rightly said, sir, it is not mandatory for all patients unless we are suspecting something else. Suppose in some only restricted cases we need an ultrasound. Suppose we want to know that the child is going for a resistance sports, we need a biopsy. We need to check that two kidneys are there or not. If the child is suspecting some genetic disease, we need to check other than USG, gonads or etc. If the child is having gross hematuria, is there any thrombosis in the renal vessels like this? And as you rightly pointed out, sir, urine RBC mostly are negative in classical idiopathic nephrotic syndrome. In minimal change disease, hypertension only comes in 5%. So also the microscopic hematuria only comes at 5%. But if it is same as FSGS, then the hypertension incidence is little bit more, of 10 to 15%, and also the microscopic immunogenicity is also a little bit more, around 10 to 20%, unless there is a extra some complications. So that's why these are written like. And SGPT may be sometimes whenever you are in doubt that liver or this pathology, you have already said first impression urine RE showing 4+ and no other suggestive history of liver, then SGPT is not at all mandatory test. But if a child is on long-term steroid therapy, then every 2 to 3 monthly one SGPT is required as per steroid side effect calculation, but not valid for this child. And ultrasound KOB is not necessary. We have done it because we are just expecting on 2 weeks, maybe a SRNS course, big girl with this nephrotic onset. So that's why you are counting some other screening also. That's why you have done. That's why it is highlighted also. This is a little bit lighter color, the ultrasound KOB. Okay, sir.
Okay. Okay. What is the rationality of waiting for 2 weeks after starting treatment for active tuberculosis before starting full dose steroid? In case of CNS tuberculosis, we are giving steroid and anti-drug simultaneously. So what is the rationality behind this waiting for 2 weeks? Is it still persisting? Is it still recommended? This wait for 2 weeks?
On that 2 weeks separate difference guideline, yeah. This is not this line is properly not mentioned in 2021 guideline, but the previous no. Only the INH profile mentioned, but the this line remains the same as the older one, that is the 2011 guideline, and there 2 weeks gap is maintained, and it was not updated in the current. The current guideline is mute on this part if the same thing is positive at both. But it is also rational because the CNS TB is probably a more urgent disease where we need to start ATT and steroid by default. Otherwise, there will be all inflammatory reaction will happen. But in case of nephrotic, at least even we wait for 2 weeks, we can manage the edema by some other way like albumin or lasis. And a 2 weeks gap is not that, may not be that much life threatening. So possibly this can be explanation why a 2 weeks gap is given for this type of non-lethal disease.
Yeah. Oh, non-fatal tuberculosis.
Yes, sir. Yes, sir.
Okay. Dr. Prashant, go ahead.
Yes. Dr. Das, I would like to say one word, as Dr. Sumantra said, similarly in HIV, even an HIV patient is having a TBM, you have to give the steroid with anti-tubercular drug. Then you start ART. Though otherwise we don't give the steroid in HIV where you have to give the ART. But if there's a tuberculosis meningitis, you treat with the steroid and then start ART.
Yeah. Okay, Dr. Prashant.
Yes, sir. So on the management part, there is intake salt restricted high protein diet with a daily monitored intake water of less than 300 to 4 ml per day. And we have to titrate it accordingly. Daily indoor monitoring of urine output, weight, everything should be done along with dose of medications given. Then for edema control, if there is severe edema, we can go for albumin infusion at the rate of 1 gram per kg, followed by Lasix injection if required. And if there is a presence of hypertension, then we have to go for ACE inhibitors or calcium channel blockers for BP, hypertension control. This was a child after receiving the treatment, that is albumin infusion.
You have mentioned regarding the daily intake of water less than 300 to 400 ml per day in nephrotic syndrome in children. Is it required?
So for initial few days, we try to do it just to have a decrease in swelling so that we can titrate it accordingly. But if there is
300 to 400 ml per day.
Yes, sir.
And high protein diet. Dr. Raut.
Yes, sir. Sir, actually,
comment on
none
this
of the
part.
guideline of ISPN, ICNA, KDIGO, all 3 guidelines, nobody has clearly mentioned any fluid amount what to be given in case of nephrotic syndrome. But in clinical scenario where the childs are overloaded up to 3 kilos or 4 kilos, which to be decreased this weight over a period of 5 days. So we need to have a tentative urine output around 20 to 25 kilo child. We have a tentative urine output of around 1000 ml by the use of Lasix plus minus albumin. And that time, if we give a equal amount of intake, suppose around 1000 kilo of intake, then the output, tentative output becomes very high. It is around 2 liters to make a weight loss of half kilo or 1 kilo per day. So that becomes a tough job for us. So better to have a restriction, only the liquid restriction, it's not a diet restriction. Only the free water restriction is around 300 to 400. It is not an exact amount because no literature mention it. Only up to date has 2 lines on this point that water restriction should be done. The amount also not mentioned, but in practical mathematics, we have seen that whenever the intake crosses around 800 or 1000, the edema controls become tough because either we need to give huge amount of laxatives to make it 2000 ml of urine output. Otherwise, we can intake can be dropped to 300 to 400 if no gross hypovolemia, and we can manage the rest of the thing with the diuretics around 1000 ml of urine output so that the weight loss becomes a mathematics like 700 to 800 per day for a 20-25 kilo child. And we need another 5 to 6 days to decrease around 2.5 to 2.5 to 3.
So our
But no
target,
guideline. Yes, sir. Yes, sir.
Our target is to reduce the body weight, 1% body weight, 1.5 to 1% body weight. So 300 to 400 ml per day will be very less. Insensible water loss, plus you have to think of output because you are giving diuretic, and this is only for severe edema, na? Only for severe edema. Patient usually bloated,
Yes,
but not for other cases.
May I comment?
Yeah.
May I comment?
Yes, sir.
And
Actually, Sumantro, in the previous these editions of the mention, it was clearly written that in nephrotic syndrome you can give fluid or water ad libitum. There was no restriction of the fluid in case of nephrotic syndrome. So we want to know a clear message from you. So
Yes,
should we restrict fluid restriction in nephrotic syndrome? Because we know we have to restrict fluid in the nephritic syndrome, what Professor Das was stating, the 400 milligram per meter square of the body surface. But in nephrotic syndrome, usually we give fluid ad lib.
Yes, sir.
Sumantro, please.
Whatever we are doing since last 7 or 8 years in our institute at AIMS or any other standard institute also, usually we keep water restricted for this type of severe edema. And also, as I told, update only mentioned 2 lines on this that water restriction should be done. So there is no fixed logic. As you know also, sir, we have requested Bhagat sir also on this topic because it's a gray area, sir. I cannot answer very particularly. So we are expecting some good talk on this. What is the water intake and output chart in nephrotic? Probably within very soon if Sapan sir wants. But till this is a gray.
Nephrotic syndrome.
Yes, sir. Yes, sir.
In nephrotic syndrome, either there is restriction of the fluid. Dr. Rai, I think Dr. Rai is correct. In nephritis, we do the restriction. What Professor Das said that
no doubt. No doubt. Yes,
you have to output plus daily insensible loss, that is 400 ml per square meter body surface. That is for the nephritis. But for nephrotic syndrome, the salt restriction is okay, high protein is okay. For fluid, there is no such restriction in the liquid fluid written anywhere in the body, anywhere in the book.
Actually,
Dr. Sumantro,
Sumantro has got very much introspect into the subject, so you want to listen to the horse's mouth.
There is some problem with the mute. I don't think Dr. Tapan Shina sir could not join because now he has come.
Do you hear me?
Yes,
okay. Okay, let me continue, Professor Das. No problem. I am listening, and then finally I will say some words.
Okay, sir.
Okay, no problem.
So I think in this part regarding this intake of fluid in nephrotic syndrome in childhood, if there is mild and moderate edema, which is mostly found in most of the cases of childhood nephrotic syndrome, there is no need of restriction of any intake.
Right.
Exactly. You will advise ad libitum, but monitor how much intake is there and how much output is there. So input, output, how much input is there, how much output is there, but no restriction. It is ad libitum.
Right. But for severe edema, sir, probably
in case of gross edema, yes, Dr. Rao, yes, in case of gross edema, there is need for restriction of fluid intake, but very carefully so that we can prevent hypovolemia.
Right.
That's
absolutely.
Yes, sir.
Okay. Next, Dr. Prashant, go ahead.
Yes. Then we have to start the steroid therapy for the first episode. that is prednisolone with a dose of 60 mg per meter square per day. That is a dose of 2 mg per kg per day in 2 divided dose for 6 weeks. And then if the child went in remission, then after documentation of the remission, we have to go for a alternative steroid therapy for 40 mg per meter square per day for 6 weeks on alternate days in a single dose.
Here I like to mention that if you want to get the good compliance, then daily steroid in single dose will be better than 2 divided dose. And in several studies, it is seen that there is no advantage of divided dose over single dose. Efficacy is same.
Okay.
Yes, sir.
And again, regarding this per meter square or per kg, you can go with either, but with the present weight, and when required, it is to be when you are going for per kg, as the edema will regress, then you can adjust the dose accordingly.
Yes.
And maximum dose capping should be mentioned.
Yes, the maximum dose
for daily
60
and
mg, 60 mg per day.
And 40 mg is the capping on alternate day. Yeah.
Yes.
Okay. What about your patient? This patient
Sir,
was 2 weeks of steroid, and then you started this steroid 60 milligram per meter square or 2 milligram per kg.
Sir, we started with 60 mg per meter square per day.
Ultimately, remission induced or not?
Sir, on the documented part, there was proteinuria present, but the patient didn't achieve full remission.
By 6 weeks.
Yes, sir.
Okay. Then, so there was no remission by 6 weeks time.
Yes, sir.
Okay. Then, go ahead.
Sir, then basically, sir, for the counseling part, sir, at that time we went for a renal biopsy for the patient, as we were suspecting steroid-resistant nephrotic syndrome.
Okay. So here you are just you were mentioning about the first episode, steroid responsive nephrotic syndrome, because you were just yes, the time is also short. So first episode, steroid responsive nephrotic syndrome. So there will be remission, and then you will stop abruptly this 40 milligram. What is the time of taking this steroid when you are giving this single dose?
Sir, on a single dose, sir, basically 6 weeks only.
What is the time of the day when you will advise to take it? The drug.
Sir, on the morning,
Hour of the day.
So on the morning,
How many AM to how many AM?
And why? So it is preferred after breakfast at around 8 to 9 AM. Why?
Yes.
So the interference of the hypothalamo-pituitary axis will be less if you give it at that time.
Okay.
Is it routine to give PPI or antacid with this daily dose?
Sir, it is not recommended because child have a very good capacity for that to resist. So there is no recommendation for any PPI or for giving on a daily basis. We can give steroids only. It's not necessary to give any PPI or insulin blockers along with this.
So only precaution to be taken in full stomach after breakfast.
After full, yes, sir. It's the only precaution.
Breakfast.
Yes, sir.
And you will ask whether there is any high risk for peptic ulcer syndrome. If the child is having history of that, then you can give. Or if the child is facing problem of gastritis, then only you will give. It is not routine.
Yes, sir.
most of the prescriptions, you will see it is given routinely. What about calcium? In first episode, steroid responsive nephrotic syndrome, 6 weeks daily, then 6 weeks alternate day, and you are stopping after 3 months. So what about prescription of calcium? Is it to be prescribed routinely during first episode along with this? What do you do?
I have no idea on that part.
So that is also not required. If it is prolonged steroid therapy for more than 3 months, then yes, calcium supplementation is given. Go ahead.
Yes. So then on the counseling part, we have to advise for daily urine dipstick monitoring for urine protein, daily nephrotic diary to maintain. The vaccination can be done properly. That is but live vaccine should be avoided for 2 weeks starting of steroid therapy, and extra vaccine should be given for against pneumococcal, varicella, influenza, hepatitis B. Then regular follow-up should be done even if the child is off meds and clinically fine. And if there is any presence of urine protein for 3 plus or more plus 4 plus for more than 3 days, then the child should should come for a follow-up earlier. And documentation of remission is very necessary with proper counseling for further relapse and should be done.
Prashant?
Yes, Dr. Rai. Thank you.
Told that the vaccination should be started after 2 weeks of steroid therapy. If the child is getting 2 milligram per kg of body weight of prednisolone, so will you give this vaccination? I think it should not be.
No.
Because the third line that you have written, live vaccine to be avoided till 2 weeks. It means after 2 weeks of steroid therapy, you can do it.
Yes, sir.
No. There are some guidelines from IAP, vaccination in special sequences. After stopping your therapeutic doses of steroid, you should wait at least 2 to 4 weeks for giving a live vaccine. So I want to learn from Sumant. Sumant, what is your take?
No, sir, it was a typo. It was actually stoppage.
May I comment?
2 weeks of steroid stoppage. 2 to 4, you're right, sir. 2 to 4 weeks of steroid stoppage. No, sir, it was typos. It was typos. 2 to 4 weeks of steroid stoppage.
Okay.
May I say something here?
Yes.
May I say something, sir?
Yeah.
Upon, sir.
Oh, Dr. Kripa.
The ACVIP member, we want to listen to the horse's mouth.
Okay. I like to give my comment regarding this live vaccination in case of nephrotic syndrome, when the patient is on steroid daily dose, which is immunosuppressive dose. That means 2 milligram per kg for two weeks, at least 2 weeks, or 20 milligram per day for 2 weeks. There is immunosuppression. Now, in case of immunosuppression, you have to wait for 4 weeks after stopping the steroid, daily steroid. You have to wait for 4 weeks to give this live vaccine like varicella, MMR. So for killed vaccine, it is not true. Only if I give killed vaccine during steroid therapy, even immunosuppressive dose, the seroconversion will be less. So titer will be less, but efficacy will be there. So it will be less efficacious. But for live vaccine, it will not be given. That's the take, and that is also the recommendation of this ISN.
So we are lucky to have Professor Kripa Sindhu Chatterjee, who is the ACVIP member for the last 2 terms. So I'll request Dr. Kripa Sindhu Chatterjee to share his thoughts.
Actually, thank you, Sapunda. Am I audible?
Yeah.
So actually, this statement needs modification. What Meenal sir has told is absolutely right. He's always like academician like him. So it cannot be, live vaccine cannot be given after stopping immunosuppressive dose for 4 weeks. It's not 2 to 4 weeks, not 2 weeks, nothing. It is after 4 weeks.
Yes,
And
sir.
again, during this dose, well, if you give these inactivated vaccines, you need to monitor serum level because seroconversion and these things are really unpredictable. So it's better, unless it is that much emergency, you stop the steroid, wait for 4 weeks, then you give vaccine. That I practice, do follow in my own practice as well. I usually don't give any vaccine unless it is that much emergency. But well, agreed as per academia, inactivated vaccine can be given, but seroconversion is unpredictable. You have to follow with the serum levels. That's it. But this statement needs modification.
Yes, sir. Sorry for that.
Can you just compile what is your statement?
My statement is if live vaccines should not be given or may be given 4 weeks after stoppage of immunosuppression dose, like what Minal sir has told, that is 2 milligram per kg.
Yes.
For
That's
more
right.
than
Dr. Shapun.
that thing. And
2 minutes
inactivated
ago.
vaccine may be given during the steroid therapy, but the seroconversion is unpredictable and hence you need to follow them up.
Okay.
Dr. Shapun, 4 minutes to go for this session, this case.
Okay. So please.
Thank you.
1 hour. We have given 1 hour time. Please.
I think this is the last slide. Dr. Prashant?
This was a daily routine diary which was advised for the parents to make on the home basis. This was the initial investigation at the time of admission of the patient, where albumin was 2.18, hemoglobin was 14.5.
So these are not required, Prashant. These are not required now. We have discussed the treatment part also. Okay.
So this was the biopsy we did for the patient, and this was the biopsy report. That is a case of FSGS involving 18 glomeruli with collapsed segments and presence of foam cell segregate seen. And this was the genetic report. The WT1 gene positive.
Positive.
Yes.
So final comment, when it is positive, what you have started.
So at this time, the child was already shifted to USA.
Oh.
Because otherwise, it was a biopsy report taken very long after time.
Okay.
So immunosuppression was stopped after that.
Yeah.
All the immunosuppression was backed up. We started CNI also after doing the biopsy, but after genetic report came, we stopped tacrolimus, we stopped prednisolone, we kept only on Enalapril. And after every 2 weeks, 3 weeks, whenever there is edema, we admit the child, give 1 or 2 doses of albumin and laxatives, and then send home. And done a long-term counseling regarding further CKD and ESRD, and may need a future renal transplant. And in between, they have shifted back to US.
Yes. Okay. Very good case. Okay. Thank you.
Thank you, sir.
Prashant, your last slide.
Yes, sir. Thank you, everyone.
Thank you. Thank you very much.
Any comments from Dr. Tapun Srinivasa, sir?
Tapun da bolo.
ওনার মিউট প্রবলেম আনমিউট প্রবলেম চলছিল তারপরে
তাহলে
next case.
So Sumantra, should we move to the next case by Urpita?
Yes, ma'am. Yes, sir.
সুমন্ত্র নয় এবারে নীলাদ্রি হচ্ছে
নীলাদ্রি আছে
Hello. Good evening, everyone. Hello. Am I audible?
Yeah. Perfect.
Hello.
You are audible.
Yes, good evening, everyone. Yes, I am Dr. Niladri from Isro Private Kolkata. So I am inviting our PTT, Dr. Arpita, to present our case. She'll be sharing the PPT right now. Arpita, over to you. Arpita.
Okay.
Okay.
So, good evening, all. Myself, Dr. Arpita, will be presenting today a curious case of a bug. Myself, PGT from the Institute of Child Health, Kolkata, and my mentor is Dr. Niladri Bose. So, my patient is an 11 years old boy who is a resident of West Midnapur from West Bengal and presented to us with fever of sudden onset, low grade, around 100 to 102 degree Fahrenheit for last 7 days, and presence of jaundice from day 3rd of fever associated with progressive paleness and generalized weakness, and decreased appetite was present. So, in the negative history, there was no history of travel in the recent 14 days from outside. There was no history of preceding diarrhea or dysentery. There was no history of any drug intake. There was no history of any family renal disease or exposure to any pet or any animal exposure. The urine output was normal. There was no rash. And in positive history, there was associated myalgia and headache. So the patient's fever was for the last 7 days, it was gradually increasing, was subsiding on taking paracetamol, and no antibiotic was given. And patient was admitted at day 7 of fever. Associated with icterus, there was high color of urine and stool color was normal. There was no associated past history. And in birth history, the child was first born term with a birth weight of 3 kg, born out through normal vaginal delivery. He cried immediately after birth, and there was no history of any SNCU or NICU stay. The vaccination status was up to date as per the National Immunization Schedule.
You
So on
please
general
change
examination,
Okay.
So on general examination, the patient was alert, conscious, cooperative, and well
I
oriented.
think some. Hello, Dr. Urpita. I think some discussion should be there in the history part.
Okay, sir.
That will be better.
Okay, sir.
Dr. Niladri, I think this will be better.
Yes, sir. Yes, sir.
Yes. You continue with the history part, then you will
history part and some discussion in history part. What you are thinking from the history.
Okay. Sir, so my patient had presented with chief complaint of fever, which was for last 7 days. Around the temperature was documented. Firstly, it was 100 to 101, and in the later last 4 days, it increased to 102 degree Fahrenheit. And presence of sir.
So, frail child having icterus from day 3 of fever and pallor
Yes, sir.
So this is the thing. And
yes, sir.
Is there any other complaint?
No, sir. Myalgia and headache and myalgia was present.
Okay. And urine color just yellow.
Just slightly high colored. Otherwise, it was normal as per the child and the parents.
Okay. From this history, what you are thinking? What you are thinking?
So as the child,
without any bias.
Sir, maybe sir, infectious etiology. Maybe means it is suggestive of infectious etiology. Means
which infection you will think first?
Sir,
fever, pallor, icterus.
Sir, malaria.
Malaria. Very good. Malaria.
Then,
anything?
sir, next, if looking at these complaints, we can also think of acute viral hepatitis.
Acute viral hepatitis. Point against in the history.
Yes, sir.
Point against in this history part against viral hepatitis, acute viral hepatitis.
Sir,
fever
progressive
and icterus,
icterus.
simultaneous fever and icterus,
Yes,
and
sir.
is pallor.
Pallor. Yes,
Pallor.
sir. Pallor.
Okay.
Yes, sir. Sir, next means dengue fever can also come in the differentials because myalgia and
Okay. Go ahead.
okay. So in general examination, my patient was alert.
Arpita, just 1 second. Arpita, just 1 second, sir. Along with that, regarding the differentials, among other than the infectious causes, we will be also thinking of some autoimmune etiologies also, like SLE or any mucocutaneous diseases.
Yeah. Yes.
And sometimes also malignant etiologies or neoplasms also. Just for the sake of discussion.
So in general examination, my patient was alert, conscious, cooperative, with oriented to time, place, and person. Pulse rate was 110.
Mute all. Except Orpita, mute all. Orpita, please continue.
He was oriented to time, place, and person. Heart rate was around 110 beats per minute, regular and equally, pulse rate was equally palpable in all the limbs. Respiratory rate was 20. BP, blood pressure was around 100 by 68 millimeter of mercury, which was around 50th centile as per the child's age. Temperature was 98.3 degrees Fahrenheit. There was presence of icterus and presence of pallor. Otherwise, there was no edema, clubbing, cyanosis, or lymphadenopathy. Oral cavity and tongue was also normal. So coming to anthropometric examination, the child's weight was 52 kg, which was more than 90th centiles. Height was around 152 centimeter, which was in 75 to 90th centiles. And body mass index was 22.5, which was in between 90 to 95th centiles.
In this part, in anthropometry, I like to give this comment that when you are examining one child, particularly during exam, better to follow the standard deviation chart, Z-score, because if it is underweight or there is wasting, you can again classify whether it is moderate or severe, which is not possible by this percentile chart. Right. For exam purpose, it will be better to follow the Z-score, right? Okay.
Okay, sir. Then next, coming to systemic examination, around abdomen was normal in shape and size with inverted umbilicus. There was no tenderness. Liver and spleen was not palpable, and there was no ascites. No superficial veins was also seen. Chest was bilaterally clear. Bilateral air entry was equal with no adventitious sounds. Cardiovascular system, S11, S2 was audible with no audible murmur. And in CNS, the child was alert and oriented. So CNS examination was also normal. There was no focal neurological deficits. Okay.
Excuse me.
Yes, ma'am.
Dr. Dashet permission niye ami bolchi. Don't say central nervous system. It is a nervous system because you are going to see their nervous, both central and peripheral. Okay. So say only the nervous system examination.
And what is the meaning of bilateral clear? Chest bilateral clear? Is it vesicular? Whether there was any added
bilateral
clear? What is the meaning of bilateral clear?
No, it should not be.
Means a bilateral equally air entry was present with
that you write that, but bilateral clear, it doesn't carry any sense, no?
Okay, sir.
Systemic examination is GI system, respiratory system, cardiovascular system, and nervous system. Right, write that. And in respiratory system, please mention it properly, right?
Okay, sir. So next, going to investigation.
Before investigation, So after this history and general physical examination and systemic examination, now where you are standing? What is your provisional diagnosis and the differential diagnosis? Do you like to add anything or delete anything which you thought earlier?
Sir, first, my differentials come around any infectious agent, like as I told, which may cause acute renal insufficiency. And second, in my mind running is any autoimmune disorders, basically.
No. Renal. What is the point? What is the point in favor of renal insufficiency? You are saying
no, sir.
Don't hurry. Sir, ki bolchen suno? Don't hurry.
In general physical examination, what were the points? Pallor. What was the degree of pallor? Severity?
Sir, mild pallor.
Okay. There is no visceromegaly. No edema.
No edema.
No edema. Blood pressure is normal.
Yes, sir.
Now, then, have you mentioned about rash? Is there any
history? Yes, sir. In negative history, there was no presence of rash.
There is no lymphadenopathy also.
No, sir.
You mentioned, no?
Yes, sir. I have told you that there was no lymphadenopathy or presence of rash.
Okay.
So, sir, if you allow, sir, so. So from the history and examination, we were thinking of mainly of infectious etiology in absence of any wasting or any malnutrition or any oral rash or alopecia or any kind of generalized or any kind of vasculitis rash. We are mainly thinking of any kind of infectious or systemic sepsis which is causing this kind of picture.
Infectious, which infection?
Sir, it could be tropically.
Yeah. So malaria, yes.
Like dengue, malaria,
typhoid.
Typhoid, something like that, sir.
But there was no organomegaly. There was no hepatomegaly or hepatosplenomegaly. Why are you thinking of infection? The malaria or typhoid without any organomegaly, is it usual?
Because sometimes even in typhoid also that we might get very small amount of organomegaly and sometimes it might be even missed also in early diseases. So we cannot say it's just a hallmark that if there is no evidence of kind of organomegaly except malaria, definitely that typhoid can be ruled out just because in the absence of organomegaly only.
Or it's a case of non-infectious etiology.
Yes,
right.
Yes, sir.
Okay. Okay. Next investigation.
So my patient was admitted on 13/12 late evening, and by the reports we can see that total leukocyte count was 26,060 with predominance of 87% neutrophils, hemoglobin of 6.1 gram%, and platelet was 62,000, and CRP of 37.9, and urea of 130, creatinine of 1.91. Total bilirubin of 3.59 with predominance of unconjugated of 2.04, and OTPT liver enzymes were slightly deranged. SGPT was 126 and SGOT was 129. PTINR was normal and LDH was very high of 3,518.
So if the creatinine is 1.91 and the patient was not having any oliguria or edema or puffiness.
Yes, sir.
There is some doubt now. The creatinine 1.91, potassium 5.8, and patient was not having any features of AKI, clinical features of AKI, oliguria or puffiness or edema or hypertension. A bit unlikely. Dr. Niladri?
Orpita, have you shown the estimated GFR? Actually, the child, when the child was actually referred to us, the child was admitted in some outside hospital, and most likely they use some kind of diuretic therapy, something like that. So when the child presented to us, the child had minimal edema. This child was not bloated. This child, the urine output was on an average around 1 to 1.1 ml per kg per hour. So in case of AKI, that it may not be always the child will be oliguric. Hence, rather in children we get non-oliguric AKI initially for the initial insult, and then it gradually progresses to oliguric AKI.
Next.
Okay. And routine urine examination was showing presence of 15 to 20 RBCs per high power field and 1 plus of protein. So till this, what are the differential diagnoses we can thinking about? So first, there may be any tropical infection induced acute kidney injury. Second comes systemic lupus erythematosus. Third may be secondary HLH, and fourth is thrombotic thrombocytopenic purpura. So can I proceed?
Directly tropical infection induced AKI, acute glomerulonephritis, ATN, harsh, basically secondary.
Means mechanism means any tropical infection can cause acute kidney injury by either
infection induced harsh.
Yes, sir.
Okay. Okay. Secondary HLH, TTP. Why you in TTP?
Sir, because there was low presence of fever and low hemoglobin, platelet count was also on the lower side. So means in thrombotic means it can come as a differential diagnosis.
Harsh and TTP. Where will you consider harsh and when will you consider TTP?
Sir, clinically, sir, generally in HUS, in TTP, there is presence of neurological symptoms, and TTP occurs in generally it is not common in childhood, whereas HUS is mainly a disease of the childhood, and central means neurological symptoms are not generally always present.
So it can overlap, but in TTP, neurological symptoms are there. In your patient, there is no neurological feature. Okay.
Yes.
Chalo.
Yes, sir. So next, to confirm our diagnosis, we proceeded with the peripheral smear, which showed normocytic normoprobic RBCs with anisopoikilocytosis and presence of schistocytes of around 4%. Reticulocyte count was high of 32% with reticulocyte production index of 8.9%. Platelet was obviously reduced with normal morphology. So, should I proceed?
Yeah, and LDH high. So what
LDH
does it
high.
suggest?
Sir, so earlier we saw that patient was having low hemoglobin, low platelet count, deranged urea creatinine, and now on peripheral smear schistocytes of more than 2%, along with presence of very high LDH. So all the criteria are fitting in the triad of hemolytic uremic syndrome. So most probably my provisional diagnosis will be a hemolytic uremic syndrome secondary to any tropical infection.
Okay. So investigation is clear cut. It is a case of HUS. Now, what's the cause of this HUS? What is the type of HUS? That is the point of discussion. Yeah?
Yes, sir.
Okay.
Okay.
Find it out.
Okay. So next we proceeded with the next investigations. Direct Coombs test was done, which was negative. G6PD was within normal range. C3 and C4 was normal. ANA was sent, which was negative. Malarial parasite and dual antigen was done, and dengue NS antigen and IgM was done, and both were negative. So next we were thinking about what next infection can will be causing such presentation of clinical presentation. So we next proceeded with and
You got
USG. Yes, sir.
Urpita, you got the patient after 7 days of fever, na?
Yes, sir.
Dengue NH1 or dengue IgM?
Yes, sir. The NS1 was also sent. Actually, it should not be sent, but IgM1 and NS1 both were sent.
Okay.
USG abdomen was done, which was showing bilateral normal-sized kidneys with raised cortical echogenicity and corticomedullary differentiation was maintained.
Why you were interested for G6?
G6PD, sir, because as the hemoglobin was low and the child was a male child, so any hemolytic anemia means any membrane deficiencies may also be will cause acute renal injury. So
there was thrombocytopenia from the beginning.
Yes, sir.
Okay.
No, actually, here I want to add, if I'm allowed, actually, the child actually received treatment outside only. Whatever reports we are actually providing is from our institute only, and the child received different kind of medicine. What the patient actually could not produce the papers actually. So, as a part of investigations of this hemolytic anemia, we sent that report also.
Now, my question is, when I am getting the CBC report, which is showing reduced platelet in that tube, should I think of G6PD in that scenario or not?
No, sir. When there is, yes,
that's the question. Lots of investigations are there, but we should be judicious to select the investigations by our clinical examination, history, clinical examination, and in the routine, the investigation which is at hand from the initial part. Then I shall choose the next investigation. It should be like that. That is the take-home message. Because investigation, so many investigations are there, but you should be judicious. Okay. No harm to do it. Okay.
Yes, sir. Yes. Okay. Point well taken.
Okay. Next, Urpita.
So next, we thought what next infection can produce such clinical presentation, and we sent the blood outside for Leptospira IgM antibodies, which came to be positive. So
without showing any malarial report in this scenario,
sir, malarial MPDA was done.
That is to be mentioned.
Sir, dual antigen I mentioned, sir, it was negative.
Okay.
Okay, sir. So we sent Leptospira IgM antibody and it came to be positive. So our diagnosis was clear about that it is a case of leptospirosis induced hemolytic uremic syndrome. So the child was diagnosed as a case of leptospirea with acute kidney injury with probability of hemolytic uremic syndrome. DIC was our differentials, but as the coagulation profile was normal and the child was not sick looking at all, so it was ruled out. C3 and C4 was normal, which is absolutely not in case of SLE. So when the Leptospira antibody came positive, we started the child on intravenous ceftriaxone and given and as per the AKI protocol was receiving IV fluids. And our next plan was to monitor the clinical condition and then proceed accordingly. So on day 1, that is on 13th/12, my patient got admitted, and by within day 3, we got all the investigations that were not presenting to any sure cause. So on 15th/12, suspecting Leptospira IgM we sent, and on 17th, it came positive, and creatinine was also decreasing from 1.99 to 0.97. But again, we saw that on day 8, that is of 20th of December, creatinine again shown a rise of 1.03 from 0.97. And at that time, we decided that we should go ahead with a renal biopsy.
Dr. Orpita, when you thought of this leptospira or you got the report, have you sent the CPK level?
No, sir.
That is one important investigation which will help you, which usually helps. That CPK is usually raised in case of leptospirosis. Okay.
Okay.
This is the syndrome, Wells syndrome or Wells disease, which is not common in pediatric age group. Which is not common in pediatric age group. Only few cases are there. Majority are of the other variety. So you are dealing with a patient of leptospirosis having Wells disease or Wells syndrome, where the treatment is started. You have started it after 7 days, but what was the treatment history? That is very important. What was the treatment history?
Sir, but the parents were not able to produce any documents, or they were not able to give proper history also, that what they received or what just the medications they took. They only told that they were only taking PCM and some medicines. What were those medicines? We were not actually able to find it out. So that's why I have not mentioned in the history.
Why I asked this?
Hello?
In this case?
Sir, your means I couldn't hear. Sir, can you please repeat?
Why I asked this question, that treatment is very important in this case.
Sir, treatment means many nephrotox means many drugs can cause means kidney injury. So that's why many antibiotics, then NSAIDs, diuretics like furosemide can cause present means kidney injury. So drug history is important. And
actually, I asked you this question because in case of leptospira, when we get the diagnosis by this IgM ELISA, before that, if the treatment is received, then only it is most effective. Earlier the treatment, it is most effective, particularly first 7 to 10 days. Right?
Okay, sir.
That's why I asked you. Any penicillin, or actually what happens in most of the cases of scrub typhus, there is the differentiation, different DD is also leptospira, and when we use this doxycycline, that covers this leptospira also. If you give ceftriaxone, which is most commonly used drug in each and every case of infectious etiology in pediatrics, that also effective, that is effective in case of leptospira, right?
Okay, sir. So on day 8, as the creatinine again shown a rise, so we decided to go ahead with a renal biopsy, and renal biopsy was done, which showed the features of thrombotic microangiopathy and presence of acute tubular epithelial injury with hemosiderin pigment accumulation. So as the biopsy is not required in every case to confirm the diagnosis of HUS, because it is a clinical diagnosis, but as my patient was having again increasing creatinine value, so we proceeded with the biopsy, and it shown that it is a thrombotic microangiopathy. So now we can say that it was a case of hemolytic uremic syndrome due to leptospira.
Dr. Niladri.
Yes, sir.
You please give your comment in this part.
Yes, sir. Yes, sir. This question was
first of all, the patient had thrombocytopenia. And in presence of thrombocytopenia, what was done? when one is considering renal biopsy, which is also not indicated in this scenario.
Yes, sir. Yes, sir. Actually, sir, this portion of the treatment was not very easy because it's often debatable. Because first of all, we have got leptospirosis or Welch disease, which itself can cause AKI and thrombocytopenia. The child initially responded ceftriaxone. By 2 days, the child became afebrile. The child was maintaining everything, and the creatinine value also was stabilizing. Porpita will show the graph later on. But again, to our utter surprise, on ceftriaxone day 5-6, the AKI was started worsening again. Since we are following the HUS guideline, in the guideline only it is said that the most common the indication of renal biopsy in case of any HUS is either the diagnosis is not clear, or number two, when the diagnosis is confirmed but the AKI or the treatment failure or the clinical scenario is worsened. Number three, we were also thinking of whether there is any underlying crescent or any evidence of IFTA, that is interstitial fibrosis or tubular atrophy, because many times we have seen that patients with underlying any kind of GN or chronic GN with subsequent or concomitant infections, the things actually become superficial. So if had there been any evidence of crescent, then the management would have differed. We would have been more aggressive in managing this case. That is why we did the biopsy, number one. Number two is the presence of thrombocytopenia is not the absolute indication of renal biopsy. Sometimes also we have done pre-biopsy from platelet transfusion, and then under the cover also we have performed renal biopsy under USG guidance. So the main motive was two, that is what was going inside the kidney, number one, which would warrant any kind of aggressive therapy or not, or any kind of fibrosis have already set in is there or not.
Dr. Bose, have you given platelet transfusion? Because the platelet count was almost in the tune of 60,000. Have you transfused platelet?
No, sir. In 60,000-70,000 also, sir, we anything in PICN also, anything above 50,000, we usually, sir, do not transfuse the platelet anything. If there is any kind of bleeding diathesis already present or below 50,000, we can do the biopsy safely under platelet cover.
Yes. Tissue thromboplastin will be helping. No need of giving platelets.
Absolutely, sir. Absolutely, sir. So, sir, this area is a little bit of gray area because leptospirosis itself can cause. There are n number of literature case reports are there, but leptospira with associated thrombotic microangiopathy or HUS, later on we searched, because initially we didn't search. We were simply following the HUS guideline. Even also we didn't do the scrub, and because scrub is also a close differential of this condition, but there was no evidence of any rash or any kind of history of there. Even our guideline says regarding the diagnosis of HUS, if you are suspecting infectious related HUS, you rule out three things first, that is the dengue, malaria, and leptospira is clinically indicated. Then you definitely think of other infectious etiologies later on.
No, Dr.
Sorry, is Shagato Chakraborty there? I can see Dr. Shagato Chakraborty. In fact, I was also in Institute of Child Health, and Shagato was my PGT, and we had a series of leptospirosis, and he was doing research at that time, Shagato. So we had series of leptospirosis at that time.
I think in leptospirosis, the thrombotic microangiopathy, you will not get that. Histiocytes you will not get. You will not get that typical this triad of us. So am I right? So if I am getting that cystocytes in the tune of 4% or 5%, so that is saying that it is harsh.
Yes,
it is not only leptospirosis. It is harsh.
Yes, definitely.
Right?
Sir,
so
there was
no
one confusion of mine that histiocytes are nothing but spinated or damaged RBC cells. So in a setting of any sepsis-induced, suppose hemolytic anemia or any kind of hemolytic anemia, will there be should be some cystocytes present? No?
It is microangiopathy, thrombotic microangiopathy. This cystocytes is found in thrombotic microangiopathy. So there was no confusion regarding the diagnosis of HAS. Okay, if the improvement renal function was deteriorating, then it is important when I should say the patient is not responding, the time period is 2 weeks, then I can say that it is rapidly progressing renal failure. Then yes, that is one indication for renal biopsy. Suppose you get crescent here. You get crescent here. Will you go for aggressive therapy, means cyclophosphamide or other things?
Sir, if had there been evidence
You
of
have to go for diagnosis of HAS. What is the etiology of HAS? Other things to be excluded, and then you will decide the treatment protocol, right?
Absolutely, sir. These things are there in
next part of the next part of the presentation. Orpita, go ahead.
Yes, sir. Yes, sir. So we did a renal biopsy and the results are as shown. So the renal biopsy was done on 20th of December and with a creatinine of 1.01. And again on 23rd, that is day 11th of admission, creatinine was gradually decreasing from 0.99 to 0.73. So we next proceeded with as the creatinine in the between shown a rise, so we decided to go with next set of investigation to look for some atypical HUS causes, because in first the creatinine was improved, but again in between it's shown a rise. So many cases of atypical HUS may be means in various cases it is triggered by an infectious etiology. So we proceeded with anti-complement factor H antibody, which was negative, and genetic panel for HUS was also done, which was negative. And so we have continued our symptomatic management.
Yes, it is mandatory to send the genetic panel is mandatory.
So as the investigations can. Yes, sir.
Yes, this genetic panel is mandatory. If affordability is there, it is mandatory even in these cases, because the underlying this genetic abnormality, maybe mutation, may be there.
Yes, sir.
Also, explain karo, able to explain karo.
Sir, actually, it is not. It means it is not mandatory in each and every case. But as our patient was deteriorating at the mid time, because the creatinine was increasing again. So
Dr. Orpita,
yes,
the as per guideline, this infection,
yes,
other infection associated HAS, this genetic panel is mandatory when you are dealing with other infection, because actually inadequate penetrance may be there in this genetic mutation cases. So this panel is mandatory if even you are getting this your scab or patient, so other infection. So this genetic panel is mandatory. There is no confusion about it.
Okay, sir.
And it is negative in you.
Yes, sir. Yes, sir. Sir, should I proceed?
Yeah. Okay.
Yes, sir. So we can see the gradual progression of the laboratory parameters. That first the patient presented with a low platelet and hemoglobin of 6.1 and 62,000, with urea and creatinine on the higher side, with LDH also was high, and gradually the platelet was decreasing. And on 20th of 12, we can see that the creatinine was again increasing. So at that time we did a biopsy, and gradually when the leptospira antibody came positive, we started the child on injection ceftriaxone, and Gradually, the hemoglobin and the platelet count improved on its own, along with decreasing in urea and creatinine levels. Along with that, schistocyte count was reduced to occasional, and reticulocyte count was also decreased from 32% to 3.7%. So our case was stamped as a case of leptospirosis-induced hemolytic uremic syndrome. That was a bug which was causing all such manifestations in an 11-year-old boy.
Thank you. It was nice case.
Sir, some more slides are there. So we have some case reports from British Medical Council as well as from Ireland journals that leptospirosis may presenting with features of thrombotic microangiopathy as well as hemolytic uremic syndromes. Also, leptospira is a very known zoonotic infections in the tropical countries, and in India it is basically more common in the southern parts, whereas it may cause acute kidney injury and acute kidney injury by affecting the tubules and as the manifestations we have seen. So in the leptospira has it causes hemolytic uremic syndrome or features of thrombotic thrombocytic purpura due to severe endotoxin injury by the leptospirosis. The outer membrane of the leptospira consists of LPS lipopolysaccharides and outer membrane protein that stimulate the adherence of neutrophils to endothelium and platelet aggregation and consumptive coagulopathy, suggesting a role in the development of thrombocytopenia. So by now, what we have learned that if a hemolytic uremic syndrome is secondary to some infection, so we should aggressively look for the infectious etiology, and only just treating that infection, the clinical improvement is must to occur. And just because it is hemolytic uremic syndrome, we don't have to jump to plasmapheresis. Long-term follow-up is required because there is always chance of relapse, and relapse chances are all is generally present in case of atypical HUS where there is a genetic predisposition. So always it is preferred to do a genetic testing so that there is no any significant adverse effect later on. Our patient has came to follow up 2 days back, and there was absolutely he was having normal blood pressure, urine routine examination was normal, along with blood parameters was normal. So this is the case. So thank you all.
Very nice presentation. I think this was very good case. But one thing is important, that whether this renal replacement therapy was required in this patient or not, most probably not required.
No, sir, it was not required.
So patient was not improving. Patient was not improving. The patient was not improving. This statement will come after this renal replacement therapy in a patient of AKI. So, and in most of the cases of HUS, the renal biopsy is not required. If it is required, it is to be done in selective cases, definitely in complicated cases. But the case was very nice, and the management was very good to give the success of the critical case. Thank you very much. Thank you.
Thank you.
Shapunda.
Dr. Mahapatra. Dr. Tapun Sinha Mahapatra. Sir,
no, I think he has left. He just rang me, and I think he has left.
So over to you, Kalpana Madam.
So wonderful cases. Both the cases are very good, very clinically oriented, and we learned a lot from the discussion. Daily we are learning. Each and every case is very good. The chapter A patient is also a book we are learning daily. So thanks the presenters, I must say they have done the wonderful job, the presenters, and the mentors are the able guidance, a very good guidance to the your PGTs, and the experts, the no word for the experts, very good expertism from the Dr. Minal sir. So, and I would like to thank all the audience. I like to have a comments from the audience and type of cases they wanted to have, and I will request all the PGTs to volunteer themselves and present the cases for our clinical discussions. Thank you all, and thank you.
Thank you.
We have our offline physical clinical meet of West Bengal Academy of Pediatrics at Apollo Multi-Speciality Hospital on 28th of February. So I will request all of you, those who can afford, please join in the West Bengal physical clinical meet. So it will be starting from 1:30 p.m. sharp. So I think you all enjoyed these two cases, and thanks again to Kalpana ma'am for making it was her brainchild. So it was an excellent. In fact, we are also in the learning process, and I must thank Dr. M.K. Das. He was just taking these to a newer heights by interfering every aspect what the PGT should know. I must thank to Dr. Sumanto Raut and Dr. Niladri Bose for their able mentorship, and thanks to Somnatha also.
I thank you, Dr. Sapon. Thank you for good chairmanship as a scientific chairperson. And I will invite Dr. Atunu to say a few words. He is eager to say a few words. Dr. Atunu, your comment, please.
Yeah, thank you.
Is also there, any comment, Dr. Sumita? After Atunu.
Yeah, it was a good presentation, and I hope that this picks up. And thanks to Professor Kalpana Datto and Professor Shapon Rai for inspiring all the academic activities. And we'll be looking forward to next week when we'll have plenty of programs lined up. And I hope that there should be a healthy competition among the postgraduate students. And I would request Kalpana to send a certificate of participation to all the participants.
Yeah, we are thinking that who are presenting online will also get the certificates of appreciation.
Yeah, certificate
and I think mentors too, and the mentors too.
Yes, mentors and the experts also.
Can give the experts also, but it's beyond our.
They devoted so much time, we must send the so Somnatha prepared it.
I like to hear from Dr. Shomir Ranjan Das sir.
Shomir, please unmute.
Any senior person, Dr. Arup Roy is there, sir. Dr. Arup Roy, sir, if you want to say any comment, any suggestions to improve our clinical digital platform.
Am I audible?
Yeah.
Thank you very much. I learned a lot. I was amazed, and particularly I must offer my thanks to Professor M.K. Das, who was guided properly to extract everything which we need from the PGTs and the mentors. They have done their job excellent, and above all, Dr. Sapon Rai is there, and Kalpana ma'am is there. So we would expect more and more such important and interesting cases in near future to boost up our academic activities in the WBAP. Thank you very much.
অনেকদিন পরে তোমায় দেখলাম, ভালো আছো?
হ্যাঁ, ভালো আছো মৃণাল?
ভালো আছি।
হ্যাঁ, আমি তো
আমার বর্তমানের দিনগুলো মনে পড়ে, তোমাকে দেখলে আবার মনে পড়ে।
শিওর আমারও তাই।
Thanks Kalpana for nice start of the academic program. Thanks our PGT's nice presentation case by our two young presenters and their mentors. And I am very much thankful for the detailed discussion by our experts, Dr. Das, Dr. Tapon Sina Mahapatto, and Sopon. Very much thankful for your meticulous presentation and the works behind the scientific cases. Thank you. Please go ahead.
I request all of you, please be there in the third session. That will be on cardiology. Please be in the last Sunday. Again, block your time and date from 8 to 10. Last Sunday of the March next month. Thank you. Thank you, sir.
Anybody, any comment? Want to make any comment for the improvement of this Sandhya Pathshala? Anybody?
No comment. You have done excellent job.
I think this is okay. This is fine.
Yes, sir. Thank you.
This is very, very fine. Case presentation with first initial history, then discussion, then investigation, then diagnosis, then treatment. And this is then elaboration and all the practical points by our experts. This is very, very, very good. And very practical points should be discussed at these points, which will be helpful. As Simanto, Dr. Niladri is there very much academician, and behind are all the professors. So it is